Freburger, PT, PhD, is a professor in the Department of Physical Therapy at the University of Pittsburgh. She has over 20 years of experience as a health services researcher with expertise in pragmatic and observational designs that capitalize on existing data, like administrative healthcare claims, electronic health records, registries, and other population-based data. She received her PhD in Health Services Organizations and Research from Virginia Commonwealth University and her MS in PT and Biomechanics from VCU. And her BS is in Physical Therapy from the University of Maryland. So welcome, Janet, and thank you for presenting for us today.
Great. Well, thanks. Thanks for inviting me. And the title of my presentation is Using a Quality Improvement Framework to Address Stroke Disparities. So what I wanted to do was just spend a little bit of time defining and distinguishing between health and healthcare disparities, then review the evidence on stroke-related disparities with a particular focus on some of our work looking at disparities in rehabilitation care, and then discuss factors that contribute to disparities, and then finally end with a discussion of the challenges and opportunities to try to address these disparities, and specifically using a quality improvement framework to try to affect change. So when we talk about disparities, there are really two types of disparities. There's disparities or differences in health, and then there's disparities or differences in health care. So disparities in health are really defined as situations when there's a higher burden of illness, injury, mortality experienced by one group relative to another, so differences in health. And then disparities in health care really are referred to differences between groups in access to, use of, and quality of health care. And for these disparities, it's typically differences that cannot be explained by variation in healthcare needs. So for example, if we saw that women were more likely to get physical therapy than men for stroke, we know that women tend to have greater disability. So some of that difference could be explained by the fact that they need more therapy. So it's really looking at disparities in healthcare that are still present after you take into account the need for healthcare. So when we talk about groups, I think probably most of you are familiar with racial disparities that is in the press a lot. There's also disparities by sex, male and female disparities. There's disparities by age. There can be disparities by ethnicity. More recently, we're focusing more on disparities by gender and sexual orientation with the LGBT population. There can be disparities based on socioeconomic status, and then there can be disparities based on disability. And most of the work in this area has focused on people that have long-term or congenital disabilities, like adults with CP would be an example. So this kind of depicts what we know about disparities related to stroke. And as you can see, they're pervasive, and they're really, across the entire continuum, from the risk factors that might cause stroke to primary and secondary prevention, and then to all of the types of health care that you can receive after you have a stroke, and then the outcomes after stroke also. So we really, the literature has shown us that there's really disparities in all these points along the history of having a stroke and then the care after. So briefly, what we do know about some of the disparities: the burden of stroke is higher in African American, Hispanics, and American Indians relative to whites. Recurrent stroke is highest in African Americans, and women face greater rates of stroke, particularly at older ages. As far as risk factors in primary prevention, we know that African Americans have a higher prevalence of risk factors, specifically hypertension, diabetes, hypercholesterolemia, smoking, and physical inactivity. There's also been some literature to suggest that there are racial and ethnic disparities in knowledge of stroke warning signs. So minority populations tend to have less knowledge of stroke warning signs. There's also data that has shown that there's racial disparities in smoking cessation counseling, again, that minorities tend to receive that less. And then there's, to kind of understand why there might be disparities, the gender disparities or the sex disparities in stroke, there's been some work looking at statin use. And I guess the earlier literature indicated that women might not be getting prescribed statin as much as men, although some of the more recent stuff has kind of brought that into question. So I think it's still kind of equivocal as far as the sex disparities in statin use. As far as disparities in outcomes, we know that African Americans have greater impairment after stroke and poorer recovery. Racial and ethnic minorities in the U.S. have higher rates of stroke mortality, and women have poorer outcomes relative to men following stroke. They have more severe strokes, longer hospital stays, more disability, and more death. Next slide. And then with acute care and secondary prevention, there's been a lot of work actually looking at kind of the hyperacute care of stroke, using thrombolysis and different early treatment after someone has a stroke to try to impact the severity of the stroke. And so there's data to suggest that there's racial and urban-rural disparities in access to and timing to receiving this care. Racial disparities in the time to diagnostic testing, and then race and sex disparities in medication use. And then there's some literature on disparities in access to specialists for stroke, and then finally regional disparities in the quality of care. And this is specifically focused on the hyperacute care. There's data to suggest that depending on where you live, you may have a greater probability of getting timely thrombolytic care. So that was kind of an overview of just the some of the literature on disparities in general, and I wanted to talk more specifically about what we know about disparities in rehabilitation care. And relative to other areas, this has been less investigated, although we're starting to see more work coming up in the literature. We actually explored this, looking at physical therapy after stroke from the acute to the community setting. And this is published work if you're interested in looking at it in more detail. So what we did was we looked at Medicare data, and we looked at people who were admitted to the hospital for a stroke, and then we followed them over time to see what happened after they left the hospital and went home, and how much rehab they did or didn't get. So basically, we were looking at, we looked at whether they got any therapy in the acute setting. We looked at whether they got any therapy in the community setting after they were discharged homes, whether they got home care or outpatient care. We looked at the timing of when that care started. So after they got home, how long did it take for them to have the first home health visit, or how long did it take them to have their first outpatient visit? And then we looked at the continuity of care, and specifically whether the patient had care in the acute care and the community setting following stroke. And so our model was that, we controlled for clinical factors or need for therapy. And then we looked at county level, hospital level, and socio-demographic level factors that were associated with the use of therapy. And that, this model allows us to actually, get some idea of the extent to which there are socio-demographic disparities in use of therapy. So what we found in the acute care setting was that Hispanics and individuals of lower socioeconomic status were less likely to receive PT and OT in the acute care setting. And patients seen in metropolitan hospitals were more likely to receive PT and OT in the acute care setting. And this latter finding makes sense because typically the availability of PTs and OTs are more prevalent in metropolitan areas versus rural areas. As far as home health, we actually found that patients who were African American or dual eligible, and by dual eligible I mean they had both Medicare and Medicaid insurance, and that's considered a proxy for lower socioeconomic status. And patients who were living in poorer counties were actually more likely to receive home care. So this is not considered a disparity. That was probably driven by need, that they, that they needed the care more. But we found that even though we found that that was a positive relationship, when we looked at the timing of care, we found that African Americans and Hispanics were less likely to receive early home care. So even though African Americans were more likely to get some care when they were sent home, they didn't get it quickly relative to whites. They had to wait longer. And then as far as outpatient care, we found that patients who were African American or dual eligible were less likely to receive outpatient care, and the timing of that care was longer. They had to wait longer, or they didn't get the care as early as their white counterparts. And then for continuity of care, we basically found that African American and dual eligible, again, were more likely to have continuity of care, so they were more likely to receive acute care and home care, which was a good finding. But as far as looking at continuity from hospital to outpatient care, patients who were African American or dual eligible were less likely to have this continuity of care. And patients that were treated at hospitals with a greater proportion of Medicaid patients were less likely to have continuity of care. And again, that's kind of an indirect measure of socioeconomic status. If patients are coming from hospitals with a greater proportion of Medicaid patients, they're likely living in, poorer areas. So the question, the question that's probably coming up and that many people ask is what contributes to these stroke disparities? So if we think about health, what contributes to the disparities in actually, having a stroke or being at risk for it? We know that there's some biological factors that contribute. So there's biological vulnerability, like for African Americans are more likely to have hypertension. For women, the biological components are hormones and menopause and all that can have some impact. Behavioral components include smoking, inactivity, and diet. Physical environment can contribute. If you live in an area where there's food deserts or a lack of good food, lack of green space, and lack of sidewalks and things that can promote better and healthier behavior. There's also sociocultural influences. Basically, your socioeconomic status, the response to discrimination can be stressful, which can increase your risk for stroke. And then insurance coverage. If you don't have good insurance coverage, you can't get the care that you need, which ultimately impacts your health. And then finally, the healthcare system has an influence on disparities in stroke. Whether the patients are health literate, what their treatment preferences are, what provider behavior is, and availability of services. And we're going to talk a little bit more about this on the next slide, because basically this bottom things is things that impact, impact healthcare use, which ultimately impacts health. So things that contribute to health care disparities are at the patient level, patient choice. Patients might make a choice not to get certain care, even if it is the best care. That might be related to their health literacy or their understanding of their problem. There can be language barriers to getting appropriate care. There can be transportation challenges and insurance coverage, which can be a big barrier, and we've seen that a lot in rehab, particularly getting outpatient rehab. There's provider level things that can contribute to healthcare disparities. That's basically things like prejudice and stereotyping and bias, even if it's unconscious. And then finally, at the healthcare system level, healthcare disparities might be the cause of differential availability of providers, that providers like to practice in certain areas more so than others, and that can contribute to disparities if there's not, the availability of providers. And then there's financial incentives for current payment structures. So if certain insurances pay better, providers might tend to try to attract those types of patients at the expense of not delivering care to other types of patients that might not have as good a coverage. So the next question is like, well, how can we reduce these disparities? I mean, these disparities are disturbing. I mean, there's stroke's not the only diagnosis where we see disparities. We really see them. The disparities pervasive across all kinds of diagnoses and across all kinds of health care. And obviously improving them will improve the health of the minorities or the the populations that are impacted by these disparities. But it's also a public health issue, and just improving the population health as a whole has ramifications beyond just improving the health of the individual. But we know that it's a pretty complex problem, and it's kind of daunting to think how you can affect change in this, because it's so many levels contribute to it, and it can be kind of overwhelming thinking about like where do you even start. So what I wanted to talk about is an approach that's been supported in the literature and quality improvement initiatives, and it's basically using a quality improvement framework to try to reduce disparities. So this is based on specifically on work by the Robert Wood Johnson Foundation. Again, who has done a lot of work in this area and tried to come up with pragmatic, usable approaches to begin to address disparities. And this is focused on disparities in healthcare. And so the first thing that one needs to do, or a healthcare system or a practice needs to do if they want to try to tackle this, is really just kind of recognizing, understanding, and committing to reducing disparities. So collecting data on your patients is, based on race and ethnicity or other characteristics, and looking to see how outcomes may vary by these variables, how the amount of care that they receive may vary by these variables, and then also, beginning to have a discussion with the staff on, understanding disparities, why this is an important topic, and training them someone what we know about disparities and how to improve them. The second step is to use a quality improvement framework to address these disparities. So most healthcare providers, are using quality improvement strategies to improve care. And so the thought is that you can really use these strategies and try to, in addition to, improving care in a certain area, try to understand how you could minimize any types of disparities that you have at the same time. So you want to create a culture of quality, have a QI team, and then select a local champion to help move this forward. And that's that's just kind of standard QI steps. The third thing you want to do is make equity an integral part of your QI efforts. Again, this can be kind of cross-cutting across all of your attempts to improve quality of care. You can be, keeping an eye on potential disparities and how you might have an impact on that. You want to try to determine the potential root causes of the disparities, so you can learn from the evidence and from your peers. You can consider things like the context, with like insurance, like care delivery in the home versus outpatient setting for Medicare patients. Is a situation where context is important, because we know that Medicare covers therapy in the home, but not in the outpatient, not as well in the outpatient setting, because it's under Medicare Part B, whereas in the home it's under Medicare Part A, and it's covered completely. With outpatient care under Medicare Part B, the patient has a copay each time they come to therapist, and they also have a therapy cap, so that can be a real deterrent to getting therapy and potentially a cause for disparities, because if the individuals of lower socioeconomic status are going to be less likely to be able to meet those co-pays. So trying to kind of understand what some of the root causes of the disparities may be, and then using evidence-based strategies to try to address them. And these are just some broad categories of multifactorial team-based care, culturally targeted care, patient-family involvement, and community involvement. And on the next slide, I have some more specific strategies that are relevant for the stroke population. So education is key, provider training to understand disparities, but as far as stroke, patient education and self-management and family education and understanding the risk factors, and recognizing that some of your patients may not be as health literate as others, and so trying to take that into account with the education. Engaging the community. With the Compass model, there was a big push for trying to use community-based resources. The community can also be a resource for equipment sometimes, like churches might have walkers from from patients, or wheelchairs. I mean, there's ways to try to look into the community to help address disparities for individuals that might not be able to afford the care across the continuum. Restructuring the care team. So in the Compass model, we had a PA and an APP, and in theory, those individuals could be targeting vulnerable patients, and I think that that they did do that across the across the care model, especially at the 14-day visit, where they looked at things. They looked at physical health, but they also looked at social determinants of health and how that might impact care. Number 4, improving communication and health literacy. Again, just recognizing that not all of your patients are going to be at the same level as far as health literacy, and trying to figure out ways to to communicate with them in a more meaningful manner. And kind of related to that is cultural targeting, where you customize the content and approach and messaging of your intervention to the patient's cultural background, and trying to make it more meaningful and useful for them. And then finally, trying to find financial support if you can. There's some insurance companies that will give some vouchers for care or reduce out-of-pocket expenses for the financially vulnerable. There's pro bono clinics. Again, if patients can't access formal care for rehab, they could potentially go to a senior center or the Y and get involved in a group exercise class that would be less costly. And then as you're doing this, you want to kind of implement these strategies, evaluate and adjust. And what I have here is something that is important to consider if you're trying to reduce disparities within a QI framework. So, because let's say you initiated, and I'm just illustrating some things in the figure here of Black-white disparities. So in the first one, you see that a greater proportion of Black patients have to wait longer, for the time of their first visit. In the second column, the number of visits in the first 30 days is greater for white patients than Blacks. And then in the last column, the proportion of visits that someone gets OT and PT is greater for whites than Blacks. So if you implement some kind of quality improvement effort to try to make some change in these different measures, one thing that could happen is that you could improve things for both groups. So these bar graphs might move up some, but the disparity would still be present. Another outcome could be that you actually increase the disparities because your QI effort is biased towards, towards white people, and you improve the outcome for the white patients, but you don't for the Black patients. So in essence, you would be increasing the disparity. And then the third outcome would be that you would improve the outcome more for Blacks than whites. So you would be decreasing the disparities. So in the ideal world, quality improvement effort that improved for both groups, but actually improved more for the minority population would be best. So, but just kind of understanding that, because there has been work to show that sometimes QI efforts to reduce disparities actually make them worse. And then finally, just thinking about sustaining the intervention. If you do find out things that work, the solutions need to be financially viable. You need a business case for them, and they need to be institutionalized. And so, to give you an example, and we know in the acute care setting, acute care hospitals are very focused on decreasing their readmission rates. And so let's say, they know that for stroke that the readmission rates are higher for their African American population. So ideally, ways to prevent that from, ways to try to reduce that would be trying to impact care after these patients are discharged from the hospital and sent home. But there has to be an incentive from the provider side in the community to address that. And so that's why some of these integrated models that are being proposed, or bundled models of care that are being proposed, might be a way to address that, because then you've got buy-in from both the acute care hospital and the post-acute provider. So that's an example of trying to, use a business case to sustain the intervention. And then finally, just recognizing that change takes time, and this is a huge problem. But if we start to chip away at it provider by provider, I think, we can have hopefully some lasting change. That's the end of the presentation. If there's any comments or people have questions, reach out if you need any help or anything. If I'd be curious to hear, anything that you guys are doing. I'm always interested in hearing, what frontline providers are trying to do, because it's, identifying the disparities is one thing, but it's really kind of understanding what works at the, at the individual patient and provider level. That's, trying to translate this information into something that will improve care. Thank you, guys.